defining the problem. It is important that we understand suicide statistics in order to have a better understanding of how suicide is impacting individuals and their families, globally, nationally, and in our own communities. Once we have an understanding of the statistics, we can then create suicide prevention and early intervention programs that are targeted for individuals who are at high risk for suicide. First, we will begin by looking at global statistics and then work our way down to discussing Missouri suicide statistics. Global suicide statistics. The World Health Organization considers suicide to be a global crisis, and in 2015, they report that every 40 seconds, someone in the world dies by suicide. That averages out to 2,160 deaths by suicide per day. There are an estimated 800,000 suicides worldwide, and according to studies, these numbers are projected to steadily increase. According to the World Health Organization, 79% of suicides in the world occur in low to middle income countries, though the data is still unavailable for an estimated 73% of these countries. For young adults, suicide accounts for nearly 1/3 of all deaths globally, with suicide being the second leading cause of death for those between the ages of 15 to 29. Studies show that globally, suicide rates are higher in males than in females. National suicide statistics. The Centers for Disease Control and Prevention reports that the rate of suicides have continued to rise each year, with suicide being the 10th leading cause of death in the United States. Suicide rates have continued to climb in nearly every state in America. According to the American Foundation for Suicide Prevention, in 2016 alone, nearly 44,965 individuals died by suicide, more than twice the number of homicides reported that year. This alarming statistic indicates a need for suicide awareness, especially for mental health professionals who will likely deal with a client experiencing thoughts of suicide. More than half of the individuals who died by suicide over the last 2 decades did not have a diagnosable mental health condition. This is why it is important that all individuals are assessed for suicide when meeting with mental health professionals, regardless of if they have a diagnosed mental illness. It is not just about mental health that creates the crisis. There are other factors, such as interpersonal concerns, financial strain, substance abuse, and more. It is reported that for every suicide, there are 25 individuals who have attempted suicide. If a person is a suicide attempt survivor, their risk for suicide increases dramatically. According to the research, a previous suicide attempt can be a strong risk factor for suicidal behavior later on. This is why it is critical that suicide attempt survivors receive follow-up care after their recent attempt, such as being connected to long-term mental health supports in their community. Understanding how suicide impacts different demographic groups, such as gender and age, can help professionals best target those at the highest risk for suicide in order to provide early intervention and preventative care. When it comes to gender, statistically, males in the United States are more likely to die by suicide compared to females. According to the World Health Organization, one factor contributing to this is the increased risk is that when males attempt suicide, they are more likely to utilize lethal methods such as firearms. Additionally, those who are considered middle-aged are at a higher risk for suicide within the United States, while younger age groups tend to show less suicide rates compared to middle-aged and older adults. Statistically, there are differences between suicide methods chosen by males and females. However, with both genders combined, firearms were utilized in more than half of the reported suicide deaths in the year 2016 alone. According to recent statistics released by the Centers for Disease Control and Prevention, in 2016, males are more likely to use firearms as a method for suicide, with more than half of male suicide deaths involving a firearm. Females' most utilized method for suicide is poisoning, with studies showing that 33% of female deaths by suicide in the year 2016 alone involved poisoning. When you are speaking with an individual experiencing thoughts of suicide, be sure to ask them about access to means for suicide, such as firearms, medications, and methods for suffocation. In 2016, the following suicidal behavior and thoughts were reported among adults 18 years and older in the United States. According to the study, many individuals think about, make plans for suicide, and/or are suicide attempt survivors. In the year 2016, 9.8 million adults reported serious thoughts of suicide within the past year, while 2.8 million made plans for suicide. Additionally, it was shown that 1.3 million adults attempted suicide within the past year alone. Missouri suicide statistics. Lastly, we will take a look at local suicide statistics. According to the Centers for Disease Control and Prevention, in 2016, suicide was the 10th leading cause of death in Missouri, with 1,133 reported suicide deaths that year. On average, every 8 hours, one individual dies by suicide, and unfortunately, these rates are continuing to rise. Studies have shown that Missouri residents are more likely to die by suicide than homicides. And similar to national statistics, more than half of the suicide deaths occurring in Missouri in the last year involved the use of a firearm, followed by suffocation and poisoning. Myths about suicide. There are many myths surrounding suicide, and it is important that professionals are aware of these myths so that they can treat them as such. We will be discussing and debunking 5 common suicide myths. Myth number 1. People who talk about suicide are just trying to get attention. Individuals who are talking about thoughts of suicide are oftentimes in pain and are reaching out in order to get help. If an individual reports thoughts of suicide, always take it seriously. Myth number 2. People who are suicidal will always be suicidal. This is not always the case. Thoughts of suicide can come back later in life, but that does not mean that they are permanent. Contrary to this myth, individuals can experience thoughts of suicide on a short-term basis. Myth number 3. People who die by suicide and survive will not attempt again. Research shows that this is not true. Suicide attempt survivors are at a higher risk of reattempting. Oftentimes, individuals may have multiple suicide attempts within their lifespan. Myth number 4. Only people with mental disorders are suicidal. This is false. Statistics show that 54% of individuals who died by suicide in 2016 did not have a diagnosed mental illness. It is important that mental health professionals are assessing all individuals for suicide, as mental health is just one risk factor among many others. Myth number 5. Asking if someone is suicidal plants the seed and will make them suicidal. Asking an individual about thoughts of suicide will not give them the idea for suicide. Talking about thoughts of suicide actually allows the individual to express how they feel openly and honestly. It is after talking about suicide that one can begin to learn more about the individual's situation and circumstances. Knowing the warning signs for suicide and how to get help can help to save lives. Being aware of warning signs for suicide can help one recognize when another individual may be experiencing thoughts of suicide, especially in those times in which the individual has not or refuses to disclose their suicidal ideation. Things the client may say when individuals are experiencing thoughts of suicide. You may hear the individual making remarks or jokes about wanting to kill themselves. Statements such as these is a strong indicator that one may be having thoughts of suicide. You may hear the individual say things like, "Just kill me now," or "I wish this was all over." The individual may make threats of suicide, for instance, saying, "If I don't get medical care immediately, I will suicide." Take all of these statements seriously and ensure the individual expressing thoughts of suicide is connected to help. Other times, it may sound more passive, with statements such as, "I feel like a burden to others. I just want it all to end. I wish I could sleep and never wake up. And I am no longer have a purpose or hope." All of these verbal cues are indicators of thoughts of suicide. If you hear anything that sounds like a warning sign for suicide, be direct and ask the individual if they are experiencing thoughts of suicide. Behaviors. Additionally, the following behaviors could be indicators that one is experiencing thoughts of suicide. When an individual experiences uncontrollable anger, rage is a behavior that can be observed. It is important to note that rage can be displayed differently in individuals. For instance, some individuals may display physical aggression towards themselves and others, while others may engage in only verbal aggression. An individual engaging in reckless behaviors may be an indicator of thoughts of suicide. You may observe that the individual is acting in ways that are detrimental with no regard for the consequences. These reckless behaviors can include self-harming behavior, reckless driving, and picking fights with others. Another warning sign is if you notice an increase in substance use with the individual. Substance use raises one's risk for suicide. The individual may be turning to substances to help them cope with the pain or escape their reality. If a person is suddenly giving away personal belongings, this can be a sign that they are making preparations for suicide. These personal belongings can be personal possessions, household items, and jewelry. Giving these things to loved ones may lead the individual to think that these possessions can help their loved ones to cope and remember them after their death. If you notice that an individual has persistent or excessive worry or just appears to be on edge, they may be experiencing anxiety. Anxiety can be a warning sign for suicide. Behavioral responses to anxiety include avoiding anxiety-producing situations, trembling or shaking, and restlessness. Watch for changes in the individual's eating and sleeping habits. Some may begin to eat less while others may increase their normal food intake. The same can be said for sleeping. The individual may sleep more, experience changes in sleep patterns, or report not being able to sleep at all. All of these behaviors can indicate that one is having thoughts of suicide. The individual may experience dramatic mood changes that begin to interfere with their daily functioning. Changes such as intense shifts in mood from extreme highs to extreme lows. The individual may withdraw from family and friends, choosing to spend more time alone and secluded. They may also stop engaging in activities and hobbies that they once enjoyed. If you observe any of these warning signs, talk with the person and encourage them to call for help as soon as possible. Recommended terminology. When talking about suicide, remember that language always matters. In the suicide prevention field, the phrase committed suicide is highly discouraged. Using the word committed tends to invoke negative connotations and may suggest that the individual committed a crime. Phrases such as died by suicide or suicided are considered appropriate and factual. By altering one's language, they can help those experiencing thoughts of suicide to feel safe and comfortable discussing suicide, rather than feeling stigmatized or like a criminal. The phrase successful suicide is also highly discouraged. The word successful is usually connected with positive connotations and is seen as a good thing. Instead, it is suggested that one uses the phrases completed suicide or death by suicide. If an individual has attempted suicide in the past, they are referred to as a suicide attempt survivor, due to the individual surviving the suicide attempt. And the phrase survivor of suicide refers to the loved ones of the individual who died by suicide.
The importance of being prepared. Asking the question. Observing warning signs in your client is a cue that you should ask directly about whether the client is having thoughts of suicide. There are several factors to consider when asking someone if they are experiencing suicidal ideation to ensure that clients feel they can be honest and open with you. First, it's important to make sure that you are directly asking about suicide. When we phrase the question as, "Are you thinking about harming yourself?" this can lead to confusion for both you and the client. Harming oneself can mean different things to different people. For example, a client may respond with a yes when asked this, but not because they are thinking of killing themselves, but because they engage in non-suicidal self-injury, such as cutting or burning as a coping skill for stress. In this instance, a clinician may assume that the client is suicidal when they are not. To avoid this confusion, it is recommended that phrases such as, "Are you having thoughts of suicide?" or "Are you thinking about killing yourself?" be used instead. Additionally, when we openly use the word suicide instead of vague phrases, it can be a cue to clients that you are okay with talking about this difficult topic and are a safe person to discuss this with. Second, you need to ask the question in a way that gives permission for your client to say yes. It can be easy for our facial expressions, body language, or tone of voice to convey that we are uncomfortable with this topic, and clients can and do pick up on this. Try to ask confidently and without hesitation. If our tone of voice sends messages to the client that we may be judgmental about their answer, it may make the client less likely to be honest with us, and thus harder for us as clinicians to get clients the help they need. On a related note, we acknowledge that talking about suicide is hard, even for professionals in the mental health and medical fields. But the more we talk about suicide, the easier it will become. If you find yourself feeling uneasy with this topic at first, just remind yourself that it is a normal reaction and that this will get better with time and practice. Tips for an effective conversation. Once your client has disclosed to you that they are having suicidal thoughts, here are some tips for making sure that your conversation with them is as effective as possible. Remain calm and collected. Try to remain as calm and collected as possible when your client shares their suicidal thoughts with you. When we overreact or underreact, it can deter clients from wanting to share more information with us. Clients may feel as though we are not equipped to help or are too afraid to work with them if we panic when they talk about suicidal ideation. Alternatively, if we underreact, we risk clients feeling as though we don't care about their situation or want to help them. Instead, thank the client for being honest and convey concern by letting them know you are hearing that they are struggling and want to help. Don't immediately try to solve the problems. A common mistake made when intervening with a suicidal client is immediately jumping to problem solving. This is often a function of clinicians wanting to provide quick relief to clients or because they are uncomfortable with discussing suicide and problem solving is a safer topic. However, when we move too quickly to fixing the client's problems, we miss out on important opportunities to build rapport with clients and make sure they feel understood and cared about. Too often, clients feel rushed out the door and dismissed, but making sure that you are taking the time to understand what has led the client to feel this way can help to avoid these feelings. Clients who feel heard and cared about are more likely to work with you on a way to stay safe. Accept their concerns as real and remain non-judgmental. Clinicians may find themselves disagreeing with something that a client is saying and being tempted to tell the client so. Challenging a client's thoughts may be a useful intervention in some cases, but it's important to consider whether this challenging may be interpreted as invalidating to the client. Invalidation can be harmful to the therapeutic relationship and may keep the client from feeling comfortable being open and honest. It is important to remember that what matters most is the client's interpretation of the situation rather than the clinician's. Focus on providing support and accepting all client concerns as real and valid. Take the situation seriously. In some situations, a clinician may feel there is not reason to be truly concerned about a client. For example, we find that this sometimes occurs with clients who are chronically suicidal, and it is assumed that because they experience suicidal ideation often, this means they will never actually attempt suicide. This may also happen when a clinician assumes that a client is simply overwhelmed and will get through it on their own. Ignoring suicidal thoughts and remaining passive can be dangerous. Different levels of guidance are needed for different clients. Some clients may need a lot of direction from a clinician, while others may not. Regardless of this, remember to take all discussions about suicide seriously and remain an active and engaged participant in the discussion. It's not always the time for advice. Though there may be times when advice is needed, especially in situations that are high risk, advice is generally not the first line of defense for suicidal thoughts. Many clients truly want someone to listen rather than attempt to tell them how to fix things. Clients are much more likely to follow through with ideas on how to stay safe or improve their situation if they are an active participant in a collaborative discussion, as opposed to being told what to do. Authoritative advice can lead to clients feeling dependent on the clinician for direction, which doesn't help to foster skills in clients that they can use on their own. How to react to a suicidal client. Active listening. In times of crisis, it is easy to forget basic skills that we use with clients, even though these are the times when they are needed the most. Let's go through a brief overview of active listening and validation. Active listening is when we concentrate fully on understanding what someone is saying rather than passively listening. The most important part of this skill is that it requires you to be present and engaged in the conversation. You should fully attend to your client as they discuss their struggle with suicidal ideation. Active listening requires a combination of verbal and nonverbal factors and skills. Common verbal skills used are paraphrasing, summarizing, and asking open-ended questions. Reflecting emotion is especially helpful in suicide intervention, as clients are usually experiencing some kind of intense emotion that has led them to consider ending their life. Brief verbal affirmations such as sure, right, and okay encourage clients to continue the conversation. Nonverbal cues, such as nodding, making eye contact, and using appropriate tone of voice and posture, are also signs to a client that you are listening and care about the conversation. Empathy and validation. Empathy and validation are equally important during suicide intervention. Empathy is being able to understand a client's point of view and experience without having to live it yourself. Validation is when you recognize a client's thoughts or feelings and convey acceptance of them, regardless of whether you agree with them or not. Clients often feel shame, fear, anger, and many other difficult emotions that can lead them to consider suicide. It can be extremely powerful for clients to feel that someone understands how they feel and accepts them as they are.